Welcome, Dr. Ann Freischlag. Dr. Freischlag is the CEO of Wake Forest Baptist Health and the Dean of the Wake Forest Medical School, and of course, past chair of the Board of Regents at the American College of Surgeons. And I had the honor and privilege of serving under Julianne on the Board of Regents. Welcome.
Thanks so much.
Happy that you're here with us. What I'd like to discuss with you today are two different facets because you have two very important jobs. One is CEO and one is Dean. Perhaps first we can touch upon the overall healthcare system. You see a pandemic coming your way. Of course, none of us have seen anything like this in our careers. How do you mobilize your health system so that you clear beds, so that you re-educate and redeploy people, communicate to them, ensure their safety? It's a big topic, but please cover any aspects that you're comfortable covering.
Well, sure. And I must admit, none of us have experience, right? So, and we all have had a different experience with the COVID-19, depending on how much penetrance you had, how many patients, and how quick it came. People in New York have a certain much different experience than we've here in North Carolina or in California. I think the biggest key is how abrupt it was. It abruptly hit us all. We stopped elective surgery on 3/18. And with that, you want to go really fast because you're a surgeon, but you really need to slow down and think about it. There also was incredible fear, wasn't there? Because we were scared we were going to get sick, and you had to be brave and understand what is the disease and how do we deal with it. And then at the same time as surgeons, it's really hard because you get lack of control. You can't control it. I'm used to putting a clamp on something. I'm a vascular surgeon. You couldn't do that. And then it's so uncertain, you're not sure what it is, and are you going to be good enough to handle and make it go forward? And at the same time, I had some tremendous guilt. We all had heard what was going on in China. I've been to China, as you haven't traveled to, and you're like, what was that? And I must admit, I think I might have ignored it in January and February, thinking it wouldn't bother us. So with all of that, I think it was mainly understanding people's fear, and then understanding that we were uncertain, that we needed to stop the elective surgery and move on. And so with the teams at work, we did that starting on the 18th. We have 5 hospitals in our system. One is an orthopedic hospital, so we really closed that down completely. We have a big trauma center and transplant here, so we kept that going. But we're able to get our beds down, so we had ICUs and beds, and really tried to model what was going on as it went through for the next 4 to 6 weeks. We really didn't get a lot of cases, like many places where our beds are down, elective surgeries down, clinics are empty, and all of a sudden we're lucky now that we're not going to get sick. There's no fear of the disease, but now there's fear of finance, and everybody's realizing that you can't afford to stay that empty. And so we've done things here too with furloughs, flexing nurses. All our administrative had taken some pay cuts in the next 4 months, so we're looking at that too. But we're lucky that we're going to be able to start up cases next week. We're going to start scheduled surgery, and we're going to use 3 of our places that are really COVID protected so that there aren't COVID patients there. And we're going to start up slowly to make sure we can do that. The other big concerns, of course, were PPE, and we were lucky to be able to have a great supply chain. We actually partner with Atrium Health in Charlotte. We're actually in the middle of trying to do a strategic partnership with them right now with the Federal Trade Commission, so that actually got delayed a little bit too. But we were able to get enough PPE and go forward. So I think convincing people initially it was okay that we could be scared of it, but we had to react and make it work. A lot of communication we did. I've been doing weekly videos. My teams, we get together twice a week on WebEx so we can talk to each other. And then teaching, we decided this was a great time for all of us to learn telehealth. So we have flipped our primary care and our surgical practices really to telehealth. I did my first initial patient interview, a woman from Miami last week on telehealth. Certainly post-op is great on telehealth. So it actually has given us some more skill sets as we come back.
Well, speaking of skill sets and of having people really not working, because if you've emptied an orthopedic hospital or you have entire units ready for beds, what did those people do? How did you decide to re-educate and or redeploy your workforce?
Yeah. And that is a great question. So Many of them were able to help us and be ready for the ICU. So many surgeons are prepared and can work in ICUs and are able to make that happen. We had many of them continue doing clinic visits so they could continue their evaluations and assessments on the clinics. Some of them, though, were unable to go practice their surgical skill, like my vascular surgeons who really wanted to go do elective vascular surgery, but not possible. So one of them, Dr. Velasquez, she actually decided to amplify her educational component and started weekly lectures. And she talked to 14 other sites. And so she has people from different institutions now giving weekly lectures to a series of a whole bunch of vascular fellows in our region. And now it's on sort of national. I'm giving one, I think, May 12th for her. So now she has a whole series of education for her fellows that she developed during this time, which was great. Part of this too, I think I found I couldn't be as creative as I wanted or to write a paper or a book. Somehow you're so distracted, but you were able to do educational things. So I think this was a really creative way for her to amplify her education for her fellows during that time. Some people actually took more time at home because their families are home and their kids, which was hard, and trying to balance both of those has been very difficult. So I think I actually spent time at home too, trying to figure out how do you work from home better? How do you manage webcasts and Zoom to make that happen? But I think getting some creativity either in the educational space or research space is what some have done. But now everybody's ready to come back. There's no question.
Yes, indeed. Present company included. As we will get to in a moment to speak more about education in your one of your many other roles as dean. But before doing that, I just want to follow up on one thing you mentioned, getting back to surgery. Will you be starting full tilt? You mentioned 3 of the 5 centers, or will it be, as we see in the ACS guidelines that were endorsed by the American Hospital Association, ARN, and the American Society of Anesthesiologists, start with perhaps outpatient cases that will not require a ventilator or an overnight stay or an ICU bed or a blood transfusion?
That's exactly what we're doing. So the person in charge of my surgery department is Wayne Meredith, who's the president-elect of the American College of Surgeons. And so we found actually about 60% of our cases are outpatient. And so we're actually had a team together that stratified those that really needed to have surgery, those with cancer, those with pain. I have a couple patients who are on anticoagulation that should be able to get off once they have their rib surgery, symptomatic carotid disease, those kind of things. So we actually have stratified them. We're going to start off with outpatient. We have an outpatient unit, the orthopedic hospital. We're going to do some orthopedics as well as other surgery. And we have another outpatient unit at High Point. So we're going to start at all 3 of those. We have about 150 cases going next week. We also have a facility that we built a brand new OR that's 20 miles away that we couldn't convince people to use. And so now we said, you can go down there and have a whole day of surgery. So some of our urologists and orthopedics are going there. And we're actually so excited because we actually are going to make sure that that's where we stay, because those patients actually should be in those outpatients. So we're using this opportunity to rearrange our block time, put the patients where they should be. We have just seen this week, patients are starting to come back here. They're coming to the ER with symptoms. They're coming to get admitted for other issues where I think, like you, we saw many people stay away from us. So we're actually doing a campaign showing people that it's safe to go get these surgeries at these what call COVID protected places, because we're going to screen all these patients to make sure that they don't have the disease, and also no COVID patients will be in those facilities. So we're going to see how this works. We're going to take it a week at a time. Everyone's all excited about it. The residents, I've been meeting with them once a week on a video Zoom meeting so that they can come back and start doing cases as well too, because they too want to get taught and get on with their careers as well.
Those institutions will be COVID-free for patients. What steps are being taken to ensure the employees at those facilities are COVID-free?
Well, we actually are doing in-house testing now, but our capacity isn't hundreds of tests. So we mainly are testing people that have been exposed or people with symptoms that are on the front line, but mainly using good protective equipment with those patients. All anesthesia are doing exactly what the college says to do with an N95, people out of the room. Then once they're intubated, going ahead with the procedure with the masks and goggles or shields on our faces. And then for those cases that are either in pulmonary or endoscopy, making sure that people are protected with an N95 mask.
I'd like to follow up on some of the information you started to share with residents wanting to operate. And so you've got multiple groups of learners there. You have your residents, your fellows, and then, of course, the medical students and your dean there as well. What has the impact been on medical students and residents in terms of case volume, clinical exposure? Is it something that the loss can be made up for in order to fulfill the requirements?
The medical school students have been a little bit more flexible than our PA students and our CRNA students. Our PA students actually had to finish their blocks the last 2 months to graduate. So we actually have had them on services for the last 2 months away from COVID patients so they could finish. Same with the CRNAs, they finish in August to do that. The medical students, though, we pulled them off like all other institutions did, mainly to keep them safe, but also because of PPE and making sure that they're safe. Our third years had just started. They had done like literally 8 days when we pulled them out. Our fourth years were really close to be finishing, so there were no trouble with graduation. We are going to have a virtual graduation though this year. It's May 17th. So now the third years, actually, we put them on some online training that they take every year that they look at for quality and safety. And we devised a COVID-19 module that they took for 2 to 3 weeks so they understand the disease and understand the implications. They're now just coming back to town. About 60% of our students are from out of state. And they're going to come back in quarantine for 2 weeks. We're going to teach them all about how to don and doff equipment. We have enough PPE so they'll be able to go on services. It does appear, though, when I've been meeting with the Council of Deans every week, that I'm not sure they're going to let fourth-year students travel for sub-internships this year. And I think we're going to interview them all online this year because, as you know, in the spring, some of the fellows interviews actually got bumped to virtual. So I think the fourth years are going to be virtual fourth years. So we're all going to learn how to interview them virtually. And I don't think they're going to be doing sub-internships. So they're all going to be here, which actually will give us a lot more flexibility. We're going to go to three-week blocks so they can see many, many things the third years before the fall so they can figure out what they want to do. And then also they'll have more flexibility because the fourth years will probably not be traveling. They're ready to go. I'm doing meetings with them once a week so we stay connected with them. But I think we're lucky that we're able to bring them back. There are some institutions where I know their COVID-19 patient load is so high that they're still not bringing them back in New York, New Jersey, and a few others. So I think for now, I think they're going to be able to learn a lot about the pandemic and then how to deal with post-pandemic in case we get more cases in the fall, which is, of course, people's concern as well.
With the changes you've made now to accommodate so there's no sub-Is, that obviously will change at some point in the future. Perhaps not obvious, but hopefully will change at some point in the future. But some of the other things you've spoken about, like the virtual education and the once-a-week online meetings, what permanent changes do you foresee in the curriculum that perhaps were serendipitous as a result of this pandemic, perhaps planned quickly, not serendipitous, that you think will be lasting after the pandemic?
Well, I think we're going to see a lot more online. We did quite a bit in the past, and also group online, where we actually have a group talking and discussing. Part of our deal that we're going to be doing with Atrium is to start a new regional campus in Charlotte. And I think we'll use this to make it a very modern first 2 years of med school. You know, virtual lectures, virtual anatomy, many things we can do that way. Most of my teams too say they love these huddles during the week where we have mini huddles and talk to each other and see each other. And they like that instead of waiting once a month to have meetings. So I think we're going to change sort of how we meet, that a quick 15-minute meeting, a touch base, and then certainly having WebEx and Zoom saves so much time, so much driving. I think that it's actually going to change everything we do, not only with the students, but with each other.
Well, thank you for your insights. They've been really, really helpful, giving the perspective of a CEO and Dean to share with us on from the Frontline series for the ACS COVID-19 Bulletin. It's great to see you virtually. I do hope that I can see you in person one day in the not too distant future.
Absolutely.
In the meantime, best wishes to you and yours for sustained health and safety through the pandemic.
You too. Thanks so much, Steve. Have a great day.